Hi, I'm Zev Cohen. I'm a third-year GI and hepatology fellow here at Emory, and welcome to the Fellows Research Competition. I want to talk to you today about a project we are in the middle of and coming close to completing about the creation of a novel choledocholithiasis prediction model. So choledocholithiasis in children has historically been managed surgically via laparoscopic cholecystectomy and sometimes with an intraoperative cholangiogram, and also sometimes with common bile duct exploration. Recently, though, there's been increasing availability of interventional endoscopy for pediatrics, and endoscopic approaches are more frequently being considered in the management of choledocholithiasis in children. And while ERCP is safe and effective, there may be certain settings that favor one approach over another. And we know that ERCP prior to cholecystectomy has been established as the preferred approach in adults, but that's only if the probability of choledocholithiasis is high. Now, the primary advantage to this approach is to clear the common bile duct prior to surgery and eliminate the need for intraoperative cholangiogram or laparoscopic common bile duct exploration, because those can be technically difficult and increase complications. Now, the primary disadvantage to ERCP before a cholecystectomy is a guarantee of two separate procedures that require anesthesia, with a cholecystectomy being performed after the ERCP. Another risk is that some ERCPs are going to be performed after a stone has passed, so unnecessarily or not therapeutically. So, in an attempt to match ERCP procedures with definitive instances of common bile duct stones, the ASGE, which is the Adult American Society for GI Endoscopy, came up with endoscopic guidelines to try and stratify adult patients to high, intermediate, and low risk criteria, with a recommendation that high risk patients proceed straight to ERCP. Now, the aim in our study was to do something similar for children. We wanted to create a novel pediatric choledocholithiasis prediction model using a combination of commonly available serum laboratory values and ultrasound results. And our objective was to only utilize the most commonly obtained information that's routinely collected in a non-referral center to predict those children who are highly likely to have a common bile duct stone. And what our aim is to do is use this score to then facilitate triaging pediatric patients either towards surgery or ERCP as the initial procedure of choice. So what we did was we looked at records from children who underwent either an intraoperative cholangiogram over a 10-year period, or more recently, children who underwent ERCP starting in about May 2017 at Eggleston. And we looked at all those children and we extracted their laboratory values and their imaging results. Now, we included children under 18 years old, and we only included children who were here for suspected choledocholithiasis. We had very strict exclusion criteria to try and hone this sample population exclusively to patients with cholecystolithiasis, gallstones, in those children where there was high suspicion for concomitant choledocholithiasis. And so we extracted all their information from the EMR, and then we performed univariate regression analysis to try and examine relationships between the baseline characteristics of these children and the finding of choledocholithiasis. We also applied the ASGE high risk criteria that I mentioned earlier to those patients who had all the data needed to fill out the criteria for the ASGE. After we had collected all that data, we then created this predictive scoring model. And what we did was we used logistic regression to try and create this model. And we took the model variables that were excerpted based on the best fit of something called a penalized linear model that successively optimized the outcome of interest, which in this case was the presence of common bile duct stones, over each of the independent variables that we were considering while keeping the other variables fixed. And then we cycled this process repeatedly until the model converged on the most accurate regression model. Now, this is a type of supervised machine learning to come up with the most accurate model. Once we had that model, we used Monte Carlo cross-validation to validate the model. And what our aim was to find a score threshold that would provide at least 90% specificity for finding a ductal stone, because what we wanted to do was minimize non-therapeutic ERCPs. So here are results. We ultimately had 388 pediatric patients who underwent intraoperative cholangiogram or ERCP, and following the exclusion criteria, 316 patients remained who were evaluated for suspicion of choledocholithiasis. You can see in the first table the procedural, demographic, laboratory, and imaging data for those patients, and the columns differentiate between those with a common bile duct stone present on the left and no common bile duct stone present on the right. So this baseline comparison of those with and without stones showed a significant difference in total and direct bilirubin, ALT, AST, amylase, GGT, ALK-Phos, common bile duct diameter via ultrasound, and the presence of a ductal stone on ultrasound. Interestingly, detection of choledocholithiasis via abdominal ultrasound had very high specificity of almost 97%, but very low sensitivity of 13%, which is similar to what some prior studies have showed, but even lower sensitivity in our study. One consideration is that because patients with hemolytic disease often have baseline derangements in their bilirubin and liver enzyme profiles, we did perform a subgroup analysis excluding those patients with hemolytic disease and essentially showed similar results to when those patients were included. So in creating this novel predictive model, we excerpted 4 independent variables based on the logistic regression, and those included the ALT, total bilirubin, alkaline phosphatase, and common bile duct diameter. And remember, we wanted easily available serum values and ultrasound values, so this would be uniformly applicable. You can see in the upper right-hand corner of the poster, the logarithmic-based model that we used to include those 4 variables. Under that, you can see the area under the curve based on the validation cohort that we performed, and that shows an area under the curve of about 0.74, which is similar to that of the ASGE guidelines. And our goal was to set a threshold that would provide at least 90% specificity to increase the positive predictive value of our model and almost guarantee us an impacted stone in the bile duct if we predicted one. So to wrap up, in looking at our model, deciding on the correct course of management for a child with suspected choledocholithiasis is challenging. Among tertiary centers like ours, the decision to proceed to either ERCP or cholecystectomy is often anecdotal. And then when we look at centers with fewer resources than ours, they may struggle with the appropriate threshold to transfer a child for ERCP. And availability and outcomes of both ERCP and minimally invasive surgical procedures for common bile duct stones in children have improved in recent years. And our goal is really to prevent non-therapeutic ERCP, but also to prevent unnecessarily surgical exploration of the common bile duct or to experience common bile duct retained stones. So with our predictive model, improved non-invasive diagnosis of pediatric choledocholithiasis could help target ERCPs to the patients who are most appropriate candidates for therapeutic stone extraction and also minimize ERCP in the patients without biliary obstructions. Historically, though, we know that identification of these high-risk children has been difficult. No single lab variable or ultrasound result has both high sensitivity and specificity for detecting these impacted common bile duct stones. We mentioned before, detection of those stones on ultrasound is very poor. The sensitivity is only about 13%, so it's a poor screening tool. And this is the first pediatric study to utilize commonly available data from children who underwent either of these procedures, cholangiogram or ERCP, to craft a choledocholithiasis scoring platform. If you'll indulge me just a minute to look at some of the model variables that were excerpted, recall it was ALT, total bilirubin, alkaline phosphatase, and common bile duct diameter. And the inclusion of all these variables improved the performance over any single variable alone. And what the model does is it allows the user to set the specificity threshold. In this study, we chose 90%, but the user can use any threshold cutoff. And at 90%, we had a very high positive predictive value for presence of a common bile duct stone. Looking at the total bilirubin, certainly that's a controversial model inclusion variable because alternate pathophysiology can certainly lead to increased serum bilirubin even outside of biliary obstruction. And this is particularly true in our study where about 23% of patients had a congenital hemolytic disease. Most frequently, it was sickle cell disease. We considered the benefit of further stratification or creation of a separate model for patients with hemolytic disease, but this modification could detract from the generalizability and ease of use of the model. And recall, we did retrospectively exclude these patients and found similar model performance to that of the prospective full data set. In looking at our model's performance, previous groups have created non-invasive prediction models for adult choledocholithiasis detection, and there have been suggestions of some modifications in children, but this is the first model of its kind developed from inception for children. And in examining the performance of the existing adult criteria, we found similar accuracy, sensitivity, and specificity, as you can see on the right side of the poster, to previous adult validation studies. So what are the future directions of this model? So we know that it provides a platform for ongoing optimization via supervised machine learning, as we can continue to feed variables into the machine learning model to optimize it. And to simplify implementation in the future, we will have a smartphone app with an easy to use interface for easy calculation of the probability of choledocholithiasis. Thank you for listening.